Order. The first order of business is to call the roll, please.
Rob Fechner,
Good afternoon.
Teresa Taylor,
Here.
Matthew Seha for John Chung,
Here.
Richard Gillahan, Henry Jones, Priya Mather, David Miller, Bill Slayton, Alan LaFossa for Betty Yee.
Here.
Can you please note for the record that Ms. Hollinger, Mr. Rubakava, and Ms. Brown have joined the committee at the dais today? With that, we move on to the approval of the Pension and Health Committee timed agenda. This is our first attempt at going through this. Just gives us suggested timelines to try and keep us more streamlined and on topic. What's the pleasure of the committee?
Move the agenda.
So moved by Taylor, seconded by Mather. Any discussion on the motion? Seeing none, all in favor say aye. Aye. Opposed, no. Motion carries. Item 3, executive reports. Ms. Lum?
Good afternoon, Mr. Chairman, members of the committee, Donna Lum, CalPERS staff. This afternoon, I have two updates for you on some recent initiatives and activities that have been underway with the customer support teams. First of all, I'd like to give you a brief update on the CalPERS benefit education event that we recently hosted this past weekend in Riverside. I was able to attend the event along with the CalPERS team members, and once again, it was a very successful event. Our two-day total for attendance was nearly over 1,700 attendees, which far surpasses the last time that we were in Riverside, where we had nearly 1,000 attendees. So once again, as I've mentioned month after month, our CBs, our CalPERS benefit education events, have been very well attended. It was also very evident than what we're seeing more and more as our members are coming to these events is that they are planning well ahead in advance. We noticed that they're coming with their itineraries and I've identified what workshops that they want to attend, and they've been very engaged in the workshops with lots of questions. So we're really fortunate that we have a lot of knowledgeable subject matter experts that are hosting these workshops that are well equipped to answer our member questions. In addition to that, we were very pleased to have our CEO, Marcy Frost, attend the CB in Riverside, where she was able to give a talk. We called it kind of a customer dialogue at this CB with several members, and provided information on what CalPERS is doing to build a strong foundation for our future. Certainly, Ms. Frost will give you an update in her CEO comments tomorrow. But in addition to that, this was, a great opportunity to be able to provide a lot of real-time information to members during a time when, they hear a lot of things about what's happening at CalPERS. In addition, we were very glad to see board members, both Mr. Fechner, Mr. Rob Fechner, and Miss Margaret Brown on Friday at the CB, as well as Mr. Ramon Rubacavia on Saturday. This was his first CB, and he attended all of the sessions and was able to give the team a lot of really good feedback. Our next CB is going to be held in Bakersfield on July 13th and 14th, and certainly, if Bakersfield in July can be quite hot. So if you're planning to travel to Bakersfield, hopefully you'll be able to be there and be cool. So that's my update on the Riverside CB, and again, I want to thank all the team members that put this on together. It is quite a feat to be able to do it and do it successfully, and they do it month after month. The next update is centered around activities that we have undertaken related to customer satisfaction and some opportunities to be able to engage with our members and our employers in different methods than we have in the past. As you know, we currently administer satisfaction surveys to our members and employers either via member self-service portal online, where they can give us feedback after a transaction. We also send out surveys via email as well as postal mail. And our systematic approach in gathering information allows us to gain greater understanding about the services that we're providing to our members, as well as information on what we can do to better enhance and provide even a better customer experience. Acting on the data that we gather, we are able to modify our current business processes into alignment with what our customers are expecting of us. And I'm pleased to share with you today that we have 3 new and exciting ways and methods that we are beginning to solicit additional feedback from both members and employers. They include something that we're calling our customer connections, in-person surveys at our CBs, as well as piloting an easy-to-use survey tool in our regional offices. So just a little bit about each of those. In March, we started what we're calling Customer Connections, and this is a program by which myself and senior leaders in the customer support team are making calls directly to members that have interacted with us and have received a service. Members are randomly selected through a sampling that we have, and obviously we have information from them from their surveys. And we connect with these members by not only asking questions about specifically how responsive were we when you came to us for your service, what was the degree of accuracy in the information that you received, as well as were you treated respectfully and did you feel like you were a valued member. And the benefit that we're seeing in these dialogues with our customers is we're getting a lot more feedback than we generally do on a paper survey. In addition to that, not only are they providing us comments on the survey questions that we're asking, but they're also sharing other information about what is concerning them about CalPERS. And this is something that our regional office agents often hear. So it enables us, again, to take additional information, look at how we can take the feedback that we're receiving, and again, further enhance the way that we are providing our services. Thus far, the overall feedback that we're getting in these calls, we're seeing is pretty much aligned with what we've seen in our paper feedback, in that well over 96% of all the calls that we're making, we're getting positive feedback for the team. So again, this is something that we are going to continue, and into the next fiscal year, we're also going to be inviting members of the executive staff to participate in these customer calls. We've chatted a little bit about it, and certainly it will give them greater insight to the services that we're providing to our members. The second area that we have initiated additional opportunities to get feedback is at the CBs. So at the CalPERS Benefit Education event this last weekend in Riverside, we had a few team members who had tablets, and we approached members that were either waiting in line or at an exhibit, and again, asking them questions very centered around the topics that I mentioned we're asking in our Customer Connects, and just dialoguing with them and getting additional feedback. We were able to interview about 50 of the members that were at the CB, and a quick analysis of the results showed that 88% of them indicated that they had their issue resolved, while about 12% were still working through the transaction to get the inquiry completed. 88% also felt that their answer or solution was received in a very timely manner. 90% indicated that they were very satisfied with the experience, and 96% said yes, that when asked if we made them feel like a valued member, we did. So I think, again, this is demonstrating the paralleling what we've seen in other surveys, but it is, once again, another opportunity to dialogue with the members face-to-face and be able to get that feedback directly from them. And then finally, this is really exciting. This is in our regional offices. This summer, we're going to be piloting a point-of-service customer feedback tool. And so currently, we survey about 10% of the customers that come through the regional offices, which equates to about 12,000 individual members each year. About 14% of the surveys that we send out are returned, and the average level of satisfaction on those surveys is about 91%. But we believe that it's necessary to be able to get additional feedback from the members that are being counseled and served at the regional office, and that timely feedback is extremely important to us. And so as our members complete either their counseling, their paperwork, or the training that they're getting at the regional offices, they'll be provided a handheld device, which is optional. We won't mandate that every member complete the survey. But the handheld device is going to have some emojis on them. And I think you're all familiar with emojis, and you've probably seen this feedback technique used before, where you have very unhappy looking emoji to a very wide smiling emoji. And what we're hoping is that we'll get a wider participation from the members to be able to get that point of feedback immediately and to be able to gather that. It will also enable us to directly tie. So what's exciting about it is not only getting the feedback, but this ties into the current technology that we have that's being used in the regional office. So we are able to directly tie the level of satisfaction to the specific service that they received and by the specific agent that provided the service. So certainly this is going to give us a lot of information, again, that will help us to continue to look at how we can leverage the information we have and the resources and continue to enhance our service. Mr. Chairman, that completes my report, and I'm happy to answer any questions you may have.
Thank you. I do want to say that, again, the CB I thought was very successful down in Riverside. It was especially nice to see Ms. Frost there and see the interaction between her and the people who were attending. A lot of good questions, a lot of good comments when I walked around talking to people afterwards. So it's a great addition, so thank you.
You're welcome.
All right, seeing no other requests, Ms. Bailey-Crimmins.
Good afternoon, Mr. Chair and members of the committee. Leanna Bailey-Crimmins, CalPERS team member. I am pleased to highlight that the CalPERS Health Program will be sharing the final 2019 rates with you, our members and employers. Today marks another historical milestone when it comes to delivering the lowest overall aggregate premium increase. For my opening remarks, I have 3 items. First, in preparation for open enrollment, I will highlight our upcoming health benefit program workshops, which will be held at the CalPERS regional offices across the state. Second, I will highlight our desire to partner with contracting agencies to offer on-site open enrollment fairs, which will assist members and provide them timely information before open enrollment. And lastly, I'll provide an executive summary on what to expect from today's Pension and Health Benefits Committee meeting. So the health benefit program workshops, as I said, will be held at the regional offices, and they are a great opportunity for existing public agencies and school employers to review how their current health resolutions are established and hear about options that are available to them. For prospective agencies, the workshops share how others have benefited from our health program and will provide benefit details to determine if we are a good fit for their organization. As a reminder, public agencies and schools do not need to have a pension contract with CalPERS to participate in our health program. Employers can find the schedule and register online by going to the CalPERS website at www.calpers.ca.gov. For existing participating agencies, CalPERS is offering again this year an opportunity to schedule open enrollment fairs for their employees. The fairs are a great way to raise awareness on the CalPERS health program, so then again that they can make informed decisions for themselves and their families. As in the past, availability for the fairs as well as the frequency and duration of our health plan partner visits will be limited. But if you are interested, the online scheduling tool will be available in early July, so keep an eye out. And also fairs will be held between August 20th and October 5th. Today's Pension and Health Benefits Committee looks towards the future. We will be asking the committee to approve a pilot that evolves our reference pricing model to pharmaceuticals. CalPERS spends approximately $2 billion annually on pharmacy. In our current pharmacy benefit manager contract with OptumRx, there is a contractual requirement for them to implement pharmacy innovations such as reference pricing. So therefore today we will be recommending a 2019 referencing pilot for 3 therapeutic drug classes. If CalPERS experiences savings, 100% of those savings will be applied to the 2020 rates. And now for 2019 rates. Last year, CalPERS's overall aggregate rate increase of 2.33% was the lowest in 20 years. For 2019, the team strove for equal or better, and I am proud to report that we have succeeded. The HMO rate we share with you today and request your approval is 0.37%. It represents an aggregate increase across 7 HMO carriers and 9 HMO plans, which in itself is amazing. HealthLeadersMedia.com published a recent article that states that the Congressional Budget Office eyes 15% as an average premium increase across the nation. Today's CalPERS overall rate is unprecedented, and the board and team members worked hard over the last 6 months while also negotiating, I have to say, a new 5-year contract, and we did all this on behalf of our members and employers. And now let's turn the page to the CalPERS self-funded PPO plans. Today, the team will present to this committee an option to use PPO reserves to smooth the 2019 PERSCare rate. There are 2 factors we ask for you to consider. Starting in 2019, we decided to eliminate risk adjustment, where members from one plan were offsetting the cost of members for another plan. Also, CalPERS currently has PPO reserves that exceeds our required limit. Today, the team will recommend using some of these reserve funds to smooth the rate increase over 2 years versus 1. In September 2018, the CalPERS team will recommend a PPO reserve policy for this board's consideration. The policy will provide guidelines to the health program on reserves and excess monies and how to apply them to premium reductions in the future. And lastly, Mr. Chair, I'd like to take a moment of privilege and recognize Mr. Gary McCollum, our senior health actuary, who has represented CalPERS and been an advisor to this committee for 12 years. In this year alone, we negotiated the new data warehouse contract. We did a new 5-year HMO contract. We discussed and eventually eliminated risk adjustment. We eliminated risk corridor, which actually benefits CalPERS because it moves the risk to the plans. We did health beliefs. We were all involved in all this. We launched a regional study, and all of that between the program and Gary. And so I'd like to, again, recognize him. His very witty personality, his smile will be very missed. I will try not to cry. But he has been amazing, and I'd like to all of us just to recognize him for a moment. And with that, Mr. Chair, that concludes my opening remarks.
Thank you. I too want to, on behalf of the committee, thank Mr. McCollum for his continued years of service. These last 12 years, you've given us invaluable advice over that period of time, and we wish you well in your retirement. Enjoy. You've earned it. Okay. Ms. Mother.
Thank you. I also cannot resist, and I can't really see Gary, but I cannot resist just taking a moment to say, as the former chair of this committee for quite a number of years and having worked so closely with Gary and the rest of the team, just the dedication, skills, talent that Gary brought to his role here at CalPERS. And not only that, always with the members at the forefront of his mind, truly a mission-driven individual who also brought a sense of humor to the work that he did. And we're really going to miss you, Gary. Thank you for your contributions here to CalPERS.
Thank you. All right, brings us to agenda item 4, the action consent calendar. It's the minutes of May 15th. What's the pleasure of the committee?
Second.
Moved by Jones, seconded by Taylor. Any discussion on the motion? Seeing none, all in favor say aye. Aye. Opposed, no. Motion carries. Item 5 is the information consent item. Having no request to remove everything, we'll move to item 6, the proposed regulation for the definition of full-time employment. Ms. Ostrander.
Good afternoon. Renee Ostrander, CalPERS team member. Before you today is Agenda Item 6, the final draft of the proposed regulations which define full-time employment for purposes of determining CalPERS membership eligibility, reporting overtime positions, and determining compensation earnable and pensionable compensation. As mentioned in February, this regulation before you provides multiple benefits. It further solidifies the board's current resolution as a regulation, a step in further strengthening the position already established, continues the practice of the individual employer defining what is full-time, and removes the maximum cap to provide flexibility for employers. The public comment period after the approval by the board in February commenced on April 13th, and it closed on May 28th. No comments or requests for a hearing were received. So therefore, we're bringing you forward the regulation that was originally presented in February with no changes. Once approved by this board and the final signatures from the Department of Finance are received, this entire package will be sent forward to the Office of Administrative Law for final review and publishing. This completes my presentation. I'd be happy to answer any questions you may have.
Great, thank you. Ms. Mother.
Move approval.
Been moved by Mother, seconded by Gillahan. Any discussion on the motion? Seeing none, all in favor say aye. Aye. Opposed, no. Motion carries. Thank you. Agenda item 7, reference pricing pharmaceuticals by therapeutic class. Ms. Donison.
Thank you, Mr. Chair. Members of the committee, this is agenda item number 7, reference pricing by therapeutic class. Kathy Donison, CalPERS team member. I will be presenting today with Dr. Richard Sun, CalPERS Chief of Medical Office, and he's going to present the bulk of the presentation today. We're down a pharmacist, so the doctor is in. Thank you.
Good afternoon. Richard Sun, CalPERS team member. This is an action item for reference pricing pharmaceuticals by therapeutic class for basic health plans serviced by OptumRx, our PBM vendor. If you approve the proposal, it will take effect in 2019. Next slide. I'll cover the 2019 pricing strategy and our analysis and recommendation for the proposal. We'll also provide an example of how this program works, the choices our members will have, and the next steps. We'll stay on this slide then. At the April meeting, we presented various strategies for pharmacy, one of which was reference pricing. As we conducted our analysis, we determined that reference pricing by therapeutic class would be the best option. If successful and if expanded, it would replace the member pays the difference, or MPD design, and this would possibly eliminate most utilization management processes, such as prior authorizations. The reference pricing strategy improves transparency by providing options for drugs that are lower cost, but identified as a therapeutic equivalent or alternative. For CalPERS, this strategy should help lower or stabilize prescription drug costs. We wanted to start with a small number of therapeutic classes. The 3 classes we recommend are nasal corticosteroids, thyroid medications, and certain estrogens. The reason we selected these 3 were low generic utilization, formulary compatibility, and low rebate impact. Next slide. Here's an example of how reference pricing would work using a hypothyroidism drug. The cost for Tirosint, a non-preferred brand medication, is $109 per month. The member pays $50 in copay, and CalPERS would pay $59. Levoxyl is a generic. This costs $9 per month. Of this, the member would pay $5 in copay, and CalPERS would pay $4. A generic alternative to Tirosint is levothyroxine. This costs $5.77 per month. The member would pay the $5 generic copay, and CalPERS would pay 77 cents. If the member would switch to levothyroxine, the plan would save $58, as indicated on page 2 of the agenda item. Next slide. Our members will have 3 options if they are currently using a prescription drug on the reference price list. Option number 1, the member could ask their doctor to switch to a lower cost prescription. Based on one program's experience with reference pricing, approximately 85% of members will choose this option. Option 2, they can ask their doctor to request the medical necessity exception, and if this exception is approved, the member would continue paying their current copay. Something like 3% of members would choose this option. And option 3, they could continue to use their current prescription and pay the difference in cost. Approximately 12% of members are expected to choose this option. Next slide. At the previous presentation on reference pricing, there was a question about what we would consider criteria for success. Based on previous evaluations of reference pricing, both in the pharmacy and non-pharmacy arenas, the proposal will be considered a success if it reduces costs to members to CalPERS while keeping member satisfaction, as determined by surveys, and adherence, as determined by claims data, at or above previous levels. Last slide. For next steps, we are seeking the approval of reference pricing by therapeutic class. We will provide extensive member, pharmacy, and provider outreach, as mentioned on page 2 of the item. The team will monitor the program and provide periodic updates to you. In addition, we will continue to research strategies to address the affordability of prescription drugs. That concludes our presentation, and Dr. Donaldson and I are available to answer questions.
Thank you. I do want to say that I'm excited about the opportunity to go through this pilot project. I think it's got some great opportunities ahead of it. I do have concerns about just assigning it to our current pharmacy managers, but I do have other board members who wish to speak. Ms. Motter?
Thank you. Yes, I think this is a terrific pilot. I think, obviously we've had a lot of success with reference pricing on the medical side, and when I talk to members, they're thrilled with the results that we've achieved through our reference pricing program. And the number one question I get is from members with respect to healthcare is, what are you doing about pharmaceutical drug prices? They are too high. And I absolutely agree with them. I think this is a very sensible step to do this pilot, and then hopefully we'll see the results and we'll be able to expand it to more therapeutic classes. I also have concerns about simply assigning this work to our PBM, and I would rather see us do a full solicitation. And so I will move that we approve the reference pricing pharmaceutical by therapeutic class program for basic health plans, and that we do a solicitation to identify who would do the work.
I'll second that motion.
It's been moved by Motter, seconded by Taylor. Next up is Ms. Taylor.
Thank you. So I want to thank you for the presentation. Excuse me. I had a couple of questions. One was similar to Ms. Mather. If we can, I don't know that having it handled under our current PBM would be the greatest idea. I know that we contract out for them to do innovative strategies. I understand that. I also understand this isn't something this is something we asked them to do, so not necessarily, they didn't think of it. So my opinion that we should maybe send this out for and I know it's only 3 medications, but I think my concern here is if we decide to operationalize this, are we, and include a larger list of medications that could be 20 or more, are they equipped to even think about doing that? So that would be my first question, and then go ahead, Ms. Donaldson.
So the reason we went with 3 therapeutic classes is because we wanted to start simple.
Right.
Because if we go up to all 87 therapeutic classes, that's where there is the bulk of the opportunity for savings, both for the plan and for the member. The reference pricing does require that we be able to access the claims or the actual Optum databases, and it is an algorithm that runs through that database based on formulary, tier 1, tier 2, tier 3. We were going to use the 3 therapeutic classes with Optum alone because it is small and there's about a $3.5 million savings. I have had, of course, I've been contracting for CalPERS, leading contracting for 8 years. And there are other ways to deal with the contract issue. It's similar to what we did with Castlight, where one company held a master contract and the other subcontracted. So that's one option. I don't know that we could do this totally independent of OptumRx. However, I think there are ways that we could manage the contract if we wish to put the subcontract piece out in terms of the algorithms, and because it does have to stay integral to the formulary and all the claims. So I think we could still do it and get to where you wanted to go without a full procurement, either as a subcontracting procurement or, as we did with Castlight, direct the master contract holder to contract with the subcontractor, we can do that under 22850 of PEMCA. So it's, I understand truly your desire to test it outside of perhaps Optum alone. I think there are ways we could get there and still have our 3 classes introduced for 2019 so that you're not having to wait another year in order to do this.
Thank you.
Okay, thank you.
Mr. LaFaso.
Thank you, Mr. Chair. Thank you for the presentation. Just a couple questions. In April, I asked some questions about subclasses. I'm curious where we are, and based on the recent comments, I'm wondering if that's something we're putting out to the bidder or to OptumRx, but the general question is, what's the thinking where we are now on subclasses?
Each therapeutic class does have subclasses. The concern, I believe, was about estrogens, and we decided to limit estrogens to 2 subclasses, which should limit the number of choices in terms of lowest cost alternatives and therapeutic equivalents.
But you're still perhaps looking at subclasses for some of the other, for the other 2, the corticosteroids and the...
No, the other 2 do not have, the reference pricing program would not assign subclasses to those. I'm talking about the other subclasses that have been done in other reference pricing pilots. For example, the one that was reported in the New England Journal had 78 therapeutic classes, and for each of those classes there may have been numerous subclasses.
Okay, appreciate that. Dr. Sun, you indicated a reduction, substantial reduction in prior authorizations, and I kind of thought when you said that you meant when the program goes across the board with lots more therapeutic classes. But is the belief about reductions in therapeutic classes, prior authorizations, not that many patients may find that what the science says is a therapeutic alternative isn't the right drug for them and their doctor supports them on that? Or is it more based on our experience with the non-pharmaceutical reference pricing program?
It's based on experience with pharmaceutical reference pricing programs, and the fact that only a low percentage of members in the previous program chose to go the medical exception route.
Okay. One last question. Do you think that physicians will generally be aware of what the lowest cost alternative is and be inclined to recommend that to your patients, or do you think patients are going to have to do a lot of effort to ask the physician to take a look at the lowest cost alternative for the patient's own fiscal benefit?
I would say in general, physicians would not be aware of the lowest cost alternative based on a particular reference pricing program design. That's why it's imperative that OptumRx and CalPERS collaborate to get the message out to providers and pharmacies and patients.
Okay. Thank you very much.
Thank you. Mr. Miller, did you mean to turn your light off? Yes. Okay. Mr. Jones.
Yeah, thank you, Mr. Chair. Looking at the benefits of this initiative, lower or stabilizes CalPERS prescription drug costs and transform healthcare purchasing and delivery to achieve affordability. How can you not support that? And so, of course, I support that, but I also am concerned about the solicitation process. So I would like to encourage you to find a way to go through some solicitation process.
I would like to add another comment to expanding the therapeutic classes. The 3, we felt that the 3 would be sort of a test case in terms of how this works so that we learn how to manage it, just similar to hips and knees. You know, we didn't start with everything we could have done with reference pricing. So this would be our way to learn how it works, how to do it. The savings, while modest now, if you go up to 87 therapeutic classes, at which point, and this is why I would consider, a subcontract type relationship with other vendors that know how to actually do this as redundancy to the program, that potential is in the $20 to $30 million range. So I don't want to lose sight that while it's a small pilot or practice now, that I believe with some of the complications with other therapeutic classes like diabetes, that really would want a collaboration in terms of outreach to providers, redundancy in how the algorithm works. Again, it has to be in concert with a formulary, including all the subclass and different ways to administer drugs, oral, injection, self-injectable, whatever that may be. So I always expected that as we expanded to more complicated, if it worked here and we wanted to generalize it, that we would really seriously consider some redundancy with a contractor who's a specialist in this area.
Okay.
Thank you. Mr. Slayton.
Thank you, Mr. Chair. On the issue of doing a separate procurement or doing some other process to possibly have someone else work with us on this, I'm just concerned about the data, and you change too many variables in it. Are you going to be able to be satisfied with the results we have, or is it due to having a different provider that's helping make that happen? So I would just be concerned about that issue of changing the underlying provider for this, and then that being part of the reason that you have a different result.
I do want to speak to the provider community particularly. They already struggle with our formulary. They're trying to manage other populations under other formularies. The reference pricing protocols actually started in Germany in 1989. When we had CVS as a contractor, we wanted to do it with CVS. We spent 2 years trying to get, CVS to move in this direction. Now the market has moved in this direction, which is good to know because we're not first out of the gate. We can actually learn from others. So in terms of the scale, in terms of physicians, it may be easier for them to deal with a reference, with a therapeutic set of data rather than necessarily 1, 2, and 3-tier formularies. So we have heard a little bit from the provider community that this would be for them an easier program, but as Dr. Sun has stated, we would want to make sure we had really good outreach to the providers, and in fact we are perhaps expanding an academic detailing project would help us do that.
Yeah, I was really referring more to the Optimum RX part, and if you change that level of communication by having a different, working with a different body, does that skew the data results that you get, as opposed to having it be from the same company? Maybe that's not maybe it makes no difference, but I'd like to know.
Well, actually, you can design the evaluation study design, I think, would take care of that.
Mm-hmm. Okay.
Because it's really about the satisfaction of the member, plus what were some of the other things, Richard, on the adherence? Yes. So I don't think it matters which one, or even if you have 2 or even 3 doing it, that adherence is really the goal, and ease of prescribing by evidence-based medicine.
Thank you.
Thank you. Ms. Mother.
So I've heard your feedback that perhaps a full-scale solicitation would make it difficult for us to actually implement this for 2019. Is that so? But I still think it stands that there's a desire, even just so that we have comfort in the results, and that our members have comfort in the results, to have another vendor participate or have a role here. So I don't know what the right language is to articulate that, but I'm happy to withdraw the solicitation language, but add something that reflects that, the desire to have another vendor involved in the execution of this pilot and the monitoring and assessment of the pilot.
So then recommending that there be a subcontract relationship between Optum, because that's where our PBM contract currently is with the data, the pharmacy data and claims data, but maybe they aren't leading the pilot. Another vendor would be the one kind of leading the information, and then we would continue to bring the results back to determine if we expand, but we'd still only be talking about 3 drug classes at this time.
Yeah, still 3 drug classes. I guess maybe I'll just say, I don't want to be too prescriptive about what device you use to get an additional vendor on board, but so I guess the question is, do we, so if the motion is to approve the reference pricing pharmaceuticals by therapeutic class program for basic health plans to be serviced by a vendor or vendors to be selected by the team, would that accomplish it? And then you've heard from the feedback from the committee, you know that means more than just Optum. Would that be satisfactory?
Yes, Ms. Member.
Okay. So that is the motion to, if my seconder
Is
is.
that acceptable to second?
Yeah.
Okay.
All right. Seeing no other requests to speak, motion being before you, all in favor say aye. Aye. Opposed, no. Motion carries. Thank you. Great presentation. Item 8, 2019 health benefits rate. 8A is the approval of the HMO plan rates. Ms. Little.
Good afternoon, Mr. Chair and members of the committee. Sherry Little, CalPERS team member. Today we're seeking approval for the 2019 health plan rates. Joining me today is the famous, infamous Gary McCollum, our health actuary, short timer. It's been an exciting year. This time of year is always crazy for the rates team, but this year has been especially exciting, I'm going to say, with the procurement of a data warehouse vendor, the contract negotiations, HMO contract negotiations, and of course the elimination of risk adjustment. So risk adjustment this was the first year since 2013 we haven't included that in our rates. So it was kind of a journey for us. We had some service area changes in addition to that. HealthNet is going to be removing from Sacramento, Yolo, and Placer counties at the end of the year. Blue Shield Access Plus is going to be exiting out of 8 counties: San Francisco, Alameda, San Mateo, Contra Costa, Santa Clara, Sonoma, Solano, and Marin. And United Healthcare is not going to be providing coverage in the Bay Area and other northern for public agencies and schools. Attachment 1 will show you the 2019 rates for state members. And as Leanna mentioned earlier, despite all the changes, we're really pleased with the weighted average of 0.37. This team worked really hard, and we appreciate your patience with us in that process. We know we threw a lot of things at you at one time in a 6-month span. But our 2018 final premiums, you'll note on these sheets, had risk adjustment. 2019 do not. 2019 rates for public agency members are also provided in attachment 2. And I'm going to move to the PPOs, but before I do, I think Ms. Bailey-Crimmins would like to make a comment.
Mr. Chair and members of the committee, Leanna Bailey-Crimmins. You may have heard earlier, because in many cases, reserves and the healthcare fund is discussed in Finance and Admin Committee. So a lot of times they are discussing the funding, but we're establishing the policy here. So I just wanted to make sure that you're aware. We do have $120 million in excess reserves for the CalPERS PPO plans. But about half of this amount has already been earmarked to buy down the Medicare PPO plan rates and to pay administrative costs that will benefit our members. Therefore, the PERSCare basic plan, we are proposing to use almost all of the remaining. So when you do the math, it comes down to about $62 million. So we're remaining of the $60 million in excess reserves to buy down PERSCare today. So I just wanted to set the record straight.
Great, thank you.
So last month, the committee requested that we bring 2 options for public comment on the PERS premiums. I'm going to turn it over to Mr. McCollum to kind of walk through what those options are.
Gary McCollum, CalPERS team member. Good afternoon, Mr. Chair and members of the board. I'd like to thank you for the kind words at the beginning of the meeting. I'm not sure I deserve them, but they are appreciated. So, thank you. We're going to look real briefly at the PERS Choice rates and the determination of them We'll start with just a real quick analysis of the demographics that are in the plans. As you can see from this slide, there's about 35,000 or so PERSCare members. Their average age is 44 and a half. On the PERS Choice, there's about 160,000, I believe, 150,000 members, and their average age is about 40. So besides the benefit differential, which, as we know, PERSCare is a 90% plan pay, and PERS Choice is an 80% plan pay, there's also the demographic differences that play into the rate calculation. And the removal of risk adjustment has generated rates that are calculated for each plan independently. And the result of the calculation for the PERSCare plan by itself is a fairly significant increase over last year's risk-adjusted rates. There is one thing that was brought up in the afternoon meeting with, was that stakeholders, in the stakeholders meeting that we just had? If you look back at 2013, the PERSCare rate that was published for 2013, the year before we started risk adjustment, was $1,029.57. This proposed rate this year, if you choose to buy it down, will be $929.89. That's actually a 10% decrease over the last 5 years. So it's just something to think about. Now if we go to the next slide. Okay, there is the reserve account status, I'm sorry, for the PPO plans. As you can see at the end of the year, it's about $120 million that's excess. And just for information purposes, we're showing the March and the April values of the fund. And you can see that the excess actually went up for March and then went down about $9 million for April. One of the characteristics of the PPO plan is that the members have to pay their deductible at the beginning of the year before the plan payments kick in. So it's common for the plan to show good results in the first 3 or 4 months. And I think the decrease from March to April is an indication that the plan is starting to pick up a little more costs. So we didn't want you to think that the fund is taking off and going to increase at this rate for the rest of the year, because there's no indication that that would happen. So the $120 million is there. As Leanna said, about half of it is still available, about $62 million, and we're proposing the buy down is estimated to spend between $35 and $50 million, which, if it goes to the high side of 50, that would leave about $12 million left, which sounds like a lot of money, but for a plan that spends $250 million a month, 12 million doesn't go very far. So I believe that finishes my comments. Oh, next slide, please. Oh, okay. So these are the two options we have for you: to approve the rate without the adjusted buy down, or approve it with the adjustment. And the adjustment really smooths the increase. It's not a buy down that will cause a snapback next year. It's essentially a step up from the current rate to the full unadjusted rate. And instead of taking the full 38% increase this year, the way to look at it is you're taking 20% of that increase this year, and you're deferring the other 18% until next year. Oh, next slide. So there are the rate possibilities. Without the adjustment, it would be $1,071.59, which is a 38% increase. With the adjustment, it would be $929.89, which is a 19.8% increase. Next slide. So now we go to the...
So we would ask Mr. Chair for a decision at this point in time, and then I believe we need to present full board tomorrow. No. sorry.
So we'll be asking for a decision on, and should we buy down or not? I know we wanted to open up for public comment to see if anybody had comment. And then based on that, we will then publish, based on the decision that you guys make, what the final PPO rates are today.
And we have to take this in 2 installments, don't we? We have to do the HMOs first and then the
Correct.
PPOs, correct? Okay, well, first of all, I just want to start off by thanking staff for the deep dive and the hard work that was put into this. You can really see that a lot of work was done. And I also want to reach out and thank the plans that actually listened last month, sharpened their pencils a little bit, and came back to the table. I just would hope in the future, next year, that in May, we're not having the same discussion and dance, that they come to the table earlier with sharpened pencils so that we can all really appreciate the fruits of everybody's labor. So I do have another request to speak before I go to the stakeholders. Mr. Jones.
Yeah, thank you, Madam Chair. The vote that you're asking for, is it just for the buy down that we just discussed, or for all the whole?
Be 2 separate votes.
2 separate votes. First for HMO, and then there'll be a second decision on the PPO buy down, and then the third decision is for the full PPO selection.
Okay.
So there'll be 3
Okay.
decisions.
Okay, so the first one is the HMO rates. I have 2 requests on 8A to speak, and that's Larry Woodson and Al Darby. Please come forward and introduce yourselves to the record. I see that Mr. Woodson's requested some extra time. Let's start with 3 minutes, but I'll let you continue speaking if you're running close. Again, this is on the HMO rates.
Well, thank you, Mr. Chairman. I realize, my comments were for both, so I guess I'll come back up
Well,
for
if you
the
want to
other.
do them
and I'll
both now, you're welcome to do so.
Thank you. Appreciate that. Mrs. Hugh will also be commenting. I did submit written comments to the board, which I hope you have read and considered, and I'm going to highlight a few of them and give additional comments based on the final rates which we just received this morning. First, I do want to talk about the lack of transparency around the staff proposal to cease risk adjustment and the board's approval of that, leading up to the December closed session in which this committee approved not risk adjusting in 2019. The staff reports in August and other times prior to that extolled the virtues of risk assessment, pointing out some liabilities as well, but the pros seem to well outweigh the cons. So you can understand why we were shocked to learn that it was abandoned in December in a closed session and approved without discussion at the Board of Administration meeting the following day. We were informed that risk adjustment was being evaluated, but never that this evaluation was going to result in cancellation. There's a difference between the two. Also, we were told that by not doing risk adjustment, 70% of the members would have lower cost plans and have their, in the lower cost plans would have their premiums go down. And this is true. The implication, though, is that these members would be saving money. And I looked at the plans, and 8 of the 13 plans in 2018 were completely covered by the monthly contribution rate for 1090 members. So much of the savings, they didn't have any out-of-pocket savings by this action, and much of the savings will go primarily to CalPERS. We were just given the final proposed rates in the stakeholder meeting, which we appreciate getting prior to this meeting. Not a lot of time to analyze it. In stakeholders on Thursday, we were informed by staff that they felt we would be pleased with these final rates. I can assure you we are not pleased with the final rates, and I'll explain why. First of all, the Anthem traditional HMO plan, Anthem apparently did not sharpen their pencils. It is not only higher significantly, they've increased it by $14 more per month since the preliminary rates were released. That represents $193 a month more for the single subscriber, or $2,400 a year. And I'd like to remind the board that you approved last year Anthem Traditional in some counties that never had this plan available to provide greater choice. And a number of our Butte County people that only had the PPO plans available migrated to this plan and were happy to get an HMO that funded 100% of non-preventative care. They're going to be shocked and very unhappy to find they're going to have to pay $2,400 more a year to retain this plan. And then PERSCare Basic. We had the asterisk 929 figure in the May. We thought that was going to go down some. It stayed the same, or increased by a penny, I think. And that will cost a single plan member $155 more a month, or $1,850 a year. That's a huge hit for the average pensioner. There's corresponding increases for the combo plan members as well. We have to support using the excess surplus funds, which we had assumed to lower these PERSCare rates, but we had assumed it was $120 million. We just found out today it's only $58 million. And we made two other recommendations in our written comments. We don't believe that you have the same constraints in setting rates for your self-funded plans as for the HMO plans with the carriers. And we encourage you to reinstitute some form of risk adjustment or adjustment among these three plans, which are your plans. You don't have to negotiate that. And make them more affordable for the basic plan members. Rather than lowering the select by $164 a month, which forces a much higher rate on care members, it could decrease. The decrease could be moderated and moderate the care increase. Finally, if the intent is to force members to migrate to select or choice, it seems like a cold-hearted tactic, and maybe it's just the result. But for those that need 90% coverage due to significant health problems, again, they're going to be forced to consider whether they can afford $1,850 more a year or not. Again, members in 18 counties can't get the HMO coverage, which would fund 100%. We believe there's time to make additional adjustments given open enrollment does not begin till September. We urge the board to reject the highest increases and direct staff to find other means to lower them. Thank you for your time.
Thank you. Mr. Darby.
Good afternoon, Mr. Chairman, committee members. Al Darby, RPEA Vice President. RPEA appreciates the work of the committee around the 2019 rates. The overall 0.32% for state is very, very attractive. A small increase is compared to what is expected in the general market, which is supposed to be closer to double digit. RPEA agrees with all of the observations that Larry Woodson has just made, and we too urge that risk adjustment be restored to the PPO plans. RPEA appreciates that an effort is in progress by the PHBC committee to eliminate or mitigate PPO regional pricing. The 2019 rates show LA Basin is 30% or almost 30% lower than SF Bay Area. Contracting agency retirees are faced with serious increases 2019 over 2018 in some areas. Many are not in Medicare, they're not Medicare age. Little or no health care allowance from their former employer is something they expect or something that they get. Their pensions average $25K a year, and many don't get Social Security. So you can see that these rates regionally, if they're somehow mitigated or eliminated, regional pricing in those high-cost areas would certainly be much more attractive to these folks and much more affordable for these facts. Thank you.
Thank you. Mr. Jones.
Yeah, thank you, Mr. Chair. Yeah, I'd just like to have staff clarify one point before we go forward. Mr. Woodson's reference to the 929 for PERSCare, and when we received that number earlier, that was in anticipation of using to draw down, using the reserves to reduce that figure, because without that reduction, I thought it was like over $1,000. And so I just want to, so the change, a penny or so, but it was already reduced from over $1,000 to this 9-something number.
So in April, the preliminary rates, the true cost of a 90/10 plan is $1,070.
Right.
And we have approximately about 34,000 people in PERSCare. What we were recommending was using excess reserve monies to buy it down, and that buy down takes it to $929.89.
Right, yeah. I just want to clarify that, Mr. Woodson, because if that anticipation wasn't there, that number would have been of $1,000, and then you would have saw a bigger drop. Okay. All right, thank you.
Thank you. Ms. Brown.
Thank you, Mr. Chair. I'd like to urge this committee and staff to retake a look at risk adjustment among the PPO plans. I know other health plan administrators are successfully using risk adjustment, and so I don't know if we can take another look at a new way of doing risk adjustment among the PPO plans. But you know, our retirees are really going to suffer under these new rates, especially for people who need a 90/20 plan, who are most at risk. And so I'm hoping that we will continue to look at how we might reinstitute risk adjustment successfully, like other administrators are doing around the state. Thank you.
Thank you. So we're on item 8A. We need to have a motion to approve the HMO rates. What's the pleasure of the committee?
Second.
Moved by Mothers, seconded by Taylor. Again, this is just the HMO portion. Any more discussion on the motion? Seeing none, all in favor say aye.
Aye.
Opposed, no. Motion carries. Pardon? Please note Mr. Jones abstaining. Brings us to 8B, the PPO organization rates. I do have 3 requests from the audience to speak. Mr. Woodson, you're done with both of those, correct? Thank you. Mr. Darby, you're done with both of those. That means Ms. Hugh. They left you alone, didn't they?
Did. And again. I guess I'll use the lit one. Hi, I'm Stephanie Hugh from California State Retirees Executive Vice President. Mr. Woodson has given you some documents, and I'm sure you've all taken a look at them, I hope, and that you will consider them as part of our input. Today, in the special stakeholder briefing this morning, we were shared with the final proposed rates for the PPOs, and while they are lower, there's still options about which way to go, and we supported the options of utilizing the excess surplus funds of $120 million when it was first brought out. What we learned today was that, and I think I heard $62 million, but I could be wrong, instead of the $120 million to help smooth. I don't know where the other money went, but it's gone, to help lower the PERSCare rates. While we appreciate the work staff has done to bring down the excess increases to the members' more expensive plans, caused primarily by the abandonment of risk adjustment, and I have a comment on that. We're going to see PERS rates of $929.89 for the basic plans for PERSCare, which represents an increase of $155 a month for a member, and annually $1,845 for a retiree. That's not chump change. We also strongly object to the raising of the Anthem's traditional rates to $193 a month more. Approximately 40,000 members and family members are on CalPERSCare Basic, and over 14,000 are retirees and their dependents. Regarding the risk adjustment, staff never really publicly informed stakeholders of their recommendation to you that it should be canceled. It was noticed in the August agenda as a topic of discussion. It went into the closed sessions at the committee, and recommendations came in the closed session and then discussed in the open session during a committee chair report, where it was voted on at that time and not agendized. So we really did not have an opportunity to give any input in that, and I don't know if that was on purpose or just a mistake. Rate changes that affect over 100,000 members should have been openly discussed and stakeholders' input solicited. In addition, we just learned of the exit of Blue Shield Access Plus, leaving 38 counties in the Bay Area.
Excuse me, just 8 counties.
I'm sorry?
8 counties. They moved from 38 to 30.
Oh, I heard my problem.
It's all right.
Hearing is a problem. Health Net leaving Sacramento areas. I guess that's Sacramento, Yolo, El Dorado, correct? Anthem Select will no longer be including University of California, Davis medical units, and that United Healthcare is leaving Northern area. Now that was sort of like a side comment. That's a big deal. And we'd like to see a map and the zip codes of these affected members to help them to begin the process of searching for new healthcare plans and providers and facilities. And that needs to be done like soon. And that's my comments. Thank you. Any questions from anybody?
I have a couple of comments, but I don't know if they're for you or not, so we'll see.
Okay.
Ms. Taylor.
Hi, so thank you, Stephanie, for your comments, and I appreciate Al and Larry, your comments as well. I think, and I think that with the risk adjustment being done away with, I know that you've talked to the staff about it and the reasoning behind it. I was wondering, though, if Mr. McCollum, as one of your last acts, if you could give us kind of a reasoning why we're looking at what we're looking at now without the risk adjustment, and how honestly what we're looking at is way better than we would have been looking at, I think, with the risk adjustment. I don't know if you can opine on that at all. I know we have some outliers, and I sometimes we don't have control over that, but I think that Mr. McCollum can answer to some of that.
What you're looking at is a calculation of each plan's rates based on their population as of 2018, projected into 2019. One of the problems with risk adjustment is that it created a lot of movement between the plans from year to year, and so the plans were always struggling with their decisions on what to project. It also had to use a risk factor from 18 months ago as the basis for the risk adjustment, and if their population had changed from that 18-month factor to now, you also had that differential that came into play. So it created a lot of uncertainty among the plans, among us. It created a lot of adjustments on the back end, which nobody sees except the plans and their sub-account balances and us staff members. But what you are seeing, though, in these rates is an actual projection by each plan, the best they could, with oversight by us and opinions by us, and then eventually an agreement by us that everything's okay for projecting into 2019, and that's the rate that's being proposed.
Right, and I think one of the things to remember is when we have some of these outlier higher rate increases, without the risk adjustment, they don't have the advantage of having this healthy pool risk adjust their rates down, and then the healthy pool of folks having to pay more. So you're also stabilized. I just think it's important that we understand why And then there were, there was legal issues that come along with risk adjustment. So I just want to make, this isn't a decision we made willy-nilly by any means. And no, we're not trying to punish anybody or drive anybody from one plan to the other. It's really just trying to make the plans more fair.
Thank you. Mr. Jones.
Yeah, thank you, Mr. Chair. I just want to comment on the transparency issue, because I know I've advocated over the last several years that we need to improve transparency. And I know staff has done a good job of moving the agenda so that more transparency could occur. And I just think back to, we started to reach out to the stakeholders to give them early information on our rates. And we even went to, a couple years ago, giving them a month in advance the rates that we were going to be looking at in June so that they have an opportunity to comment on it and give input. So since there's still some concerns on that issue, I would just like to ask that additional efforts be made to improve the transparency, because I hear about the concerns that the members raised about they felt that they weren't aware of certain actions that we had taken. So I would just want staff to reach out again and see if we could improve that transparency. I know you've done a lot, but I just think that we just need to reach out and see if we could do even more to be sure that our members feel like they're getting the information in a timely manner. Okay.
Thank you. Mr. LaFaso.
Thank you, Mr. Chair. Following a little bit on Mr. Jones' comments, I think it's fair to say at this juncture that the decision on risk adjustment came as a bit of a surprise to some stakeholders. But a question for you, Mr. McCollum, because I think you underscored a couple things in your response to Ms. Taylor, that at this juncture in time, we may be, from a rate perspective, experiencing some of the most challenging aspects of canceling risk adjustment, but some of the potential back end settling out relative to the way plans estimate their rates, the way some member migration has been driven by risk adjustment, might point in the future to some backside windfalls that might ultimately accrue to members. I'm wondering if you can comment on that, and I wonder if staff can think about how, as we fully transition out of risk adjustment, we might be able to communicate the full story to stakeholders.
I can't really agree with the concept of a backside windfall, because I don't anticipate there being any windfall. But unless you want to consider a windfall just to be a settling down of the program, if you look back historically, before risk adjustment was implemented, we tended to have approximately 3% or so of the population move from month to month, change plans. And starting in 2014 and for the last 5 years, that has jumped up to 5 to 6%. And so there's been a lot more movement. And I anticipate that that type of plan movement will settle down as the rates settle down, in essence, and the plans propose their rates, their premiums that reflect their population, and there isn't this uncertainty of what risk adjustment will do from year to year.
Maybe there's still something left in my comment to share information with stakeholders after it settles out, but I'll go to my second issue and I'll swing the bat another time on this question of migration. I'll hearken back to Ms. Bailey-Crimmins' opening comments about the aggregate holding down of rates in general, and it looks to me that there are a couple, few outlier plans with some pretty stubborn cost drivers in them. Obviously, an example would be Anthem Traditional. I'm wondering if staff has a comment on how that these rates reflect actual cost and there's no risk adjustment offset on the HMO side, what we might think about member migration given some of the disparities in rates among the plans in the new environment that's going to start in 2019.
I'll kick it off, and then maybe Sherry can add to it. So specifically, as you're aware, Anthem offers two basic plans with us. So they offer Anthem Select and Anthem Traditional. You will see that Select has gone down. It's gone down because they will no longer offer UC Davis as an offering, but Traditional will be offering UC Davis, and they're expecting a migration. As the team dug into any of the outliers, which Anthem Traditional was, it seems like at least on the basic, everything else has gone down, except Blue Shield, which is now 6%. We dug into it, and based on membership, based on claims, and they believe it was the accurate cost. And it was not, in this case, it was not a reflection of risk adjustment. It was just based on where they are in the market at this point. And maybe, Sherry, you can highlight a little bit more on that.
And I would add to that, Mr. McCollum talked about migration patterns, and with Anthem in particular, they anticipate migration from one plan to the other, and they had more population in other north as well as in the Bay Area that they didn't necessarily project for. So the elimination of risk adjustment gives everyone a little bit more opportunity to project in the way that they would traditionally. Is that accurate? Is that an accurate way of saying it, traditionally, versus not knowing the migration patterns from year to year and trying to speculate on that? So that's what I think our intent is with that, and I think some of the volatility you see is the product of eliminating that risk adjustment. You'll see every plan but two decrease this year.
Okay. Just to close out on my comment, I meant to be more broad in terms of plan choices. I still think there's another carrier in the Sacramento region that still contracts with UC Davis that someone might still be able to opt for to get to UC Davis as a provider and get around that Anthem Traditional rate increase. And I finally, just to load my questions for time, the last speaker made some comment about information and provider choices. I imagine that's something that you'll be focusing on the open enrollment fairs that you talked about in the introductory comments, Ms. Bailey-Crimmins?
That is correct. And just for members that are watching, if they are still interested in UC Davis, Blue Shield and United Healthcare both offer, in addition to Anthem Traditional, they will be offering UC Davis as an option for 2019.
And the other part of your question, we did speak with the stakeholders earlier today, and we are going to put together a plan of how we communicate best so that everyone is very well aware. We heard their concerns, and we will certainly work with them on that as we make changes.
Thank you. Thank you, Mr. Chairman.
Thank you. Mr. Miller.
Yeah, thanks very much. And happy retirement to you. I'm relatively new. I was not here for the decision on risk adjustment, so I really won't belabor that subject. The thing that concerns me going forward, and I think we'll have to really look at, is, the disproportionate impact for the winners here versus the modest improvements on an individual basis for those who've benefited from holding down the increases, which is a wonderful thing. But for folks who are choosing or feel that they need the higher cost options, whether it be the Anthem HMO, whether it be PERSCare, the hits to them are really big. And especially, stepping in a 40% increase over 2 years, it's better than getting hit with it all at once. And I'm glad that we'll have the opportunity to do that if we choose to. But it's still a huge hit for the folks mostly who are going to be having to choose that plan because they need the features of that plan, and they don't really have too many alternatives to choosing that plan. And so I don't know if we have a short-term solution to that, but I think it's something we should all pause and think about, is how do we address the needs of those folks, and not just in a vacuum, because we've also made plan changes. We've also changed the menu of choices that people may have before them who were in those plans for their needs and their reasons. So I really think we need to as good as we've done in the aggregate overall on these negotiations, and I applaud staff for the effort because I know that was tough. But looking at our members' needs, 35,000 people is not a small number. It may be a small percentage of our members. And we really, how do we better serve them going forward, knowing that we're going to hit them with another probably 20% increase or more as people migrate, as they will, if they can, leaving the people who are most in need and most at risk of struggling financially because of these hits, who are left in those plans.
Mr. Chair, I just want to point out, specifically for our PPO, PERS Select members of 50,000 individuals were paying more last year to subsidize PERSCare. And so they were paying, as we look at PERS Select, they were paying last year $661, and they are now no longer doing that. So it's about fairness. That's one of the reasons we got rid of risk adjustment, is really for it to reflect the true cost. So I just wanted to make sure that people are aware that we felt that in order to make the right decision on behalf of everyone, those were some of the conversations we had as a group.
Thank you. Mr. Jones.
Yeah, thank you. This perhaps is my last question. And it was triggered by Mr. Miller's comment about meeting the needs of our members. And several years ago, there were requests or comments regarding the combo plans. And so I understand we made real progress in terms of that. So could you comment on that? Because I know I used to get questions, why can't we have combo plans in the various plans? So if you can comment on that, I appreciate it.
Sure. Just as a reminder to everyone, so a combo family means that someone has of age of Medicare, so they are Medicare, but they have potentially a younger family that are dependents. So they're a combination family. And so what we want to make sure is, and those are individuals, those younger dependents are in basic plans. And so when we decided to go to United Healthcare as a Medicare Advantage, it did not cover all the counties last year. We had a conversation about combo families. And as such, people that wanted an HMO offering felt like they had to go to a PPO offering, which was a higher cost to them. So this board decided to go ahead and allow us to do Anthem Traditional, to expand to all counties. Going into 2019, for combo families, the following plans are available to them. United Healthcare, United Healthcare, Kaiser, Anthem Traditional, and all 3 PPOs. So there are 6 plan options for combo families.
Okay, thank you.
Okay.
Ms. Mother.
Thank you. One of the things that I think would be useful looking forward is to, now that we're several years, I think now 5 years into this competitive structure where we have multiple plans, multiple HMO plans, I think it would be useful to do an assessment of how that competition has worked and benefited, whether it's benefited our members, what the results have been. And also we could, as part of that, we could look at how the experience has manifested in terms of sicker populations and healthier populations, and how that's sort of spread across the various plans. I think that might be a useful component of the analysis to bring back at a later date. Thank you.
Great, thank you. Seeing no other requests to speak, we do have a couple of motions we have to put forward. The first one, I believe, is whether or not to use the excess to buy down the rates, correct? All right, what's the pleasure of the committee?
So moved.
Moved by Taylor, seconded by Mother. Any discussion on the motion? Seeing none, all in favor say aye.
Aye.
Opposed, no. Motion carries. Now we need a motion to approve the PPO rates for 2019.
So moved.
Moved by Taylor. Is there a second? Seconded by Mother. Any discussion on the motion? Seeing none, all in favor say aye. Aye. Opposed, no. Motion carries. Please show Mr. Jones and Mr. Miller abstaining. All right, seeing no other requests to speak on item 8, we move to item 9, state annuitant contribution formula. Ms. Little.
Thank you, Mr. Chair. I think Mr. McCollum is going to finish out his work here by talking about this a little bit. We're really putting him to work at the end. Yes.
Gary McCollum. I think it's appropriate, actually, that I finish with an agenda item that talks about retired annuitant contribution rates. So this is the retired annuitant contribution rates. Do we have slides for this? Okay. You will be receiving, or the agenda item has the 190 formula, which is the same as in years past. But this year, there's an additional formula that comes into play, and that is under Government Code Section 22871.3, which was added to PEMCA a few years ago. It creates a new retiree formula that's called an 80/80 formula. This will be used for all new hires starting in 2016 or 2017, depending on which bargaining unit they belong to. And it will be an 80% of the premium covered for the subscriber and 80% for the dependents, and it'll be based on the 4 largest Medicare plans. And for this first year, the 4 largest Medicare plans are Kaiser, United, PERSCare, and PERS Choice. Now, we're bringing this forward this year, even though it's only available to members who were hired in 2016 or 17, because there have been a small number of people who have gone out on a disability retirement hired in 2016 or 2017, and so they fall under this category. So we needed to publish that and have it made available. This group, since they just started, will grow very slowly until about 2031, when they will become their normal retirement age. And after that time, the 80/80 formula will grow significantly, and the 190 formula will correspondingly decrease as the members in that formula depart. So that's my presentation, if there are any questions.
Seeing none, thank you very much. An easy one for your last one, right? Brings us to item 10, summary of committee direction. Ms. Bailey-Crimmins.
I have 2. The first, in relation to conversations about risk adjustment, what we will be doing is looking at ways to improve our processes on transparency. So we will be adding that as an item for us to look at for. And then the second is an assessment of the effect of competition. Has it given us the outcomes we thought we wanted, and then decide if there needs to be changes moving forward.
All right, very good. Seeing nothing else on the agenda, anybody wish to have public comment that has not spoken yet? Seeing none, thank you all for your attendance. This meeting is adjourned.